My name is Alice Chen. I was asked to speak about the eReferral system at San Francisco General Hospital, which is our integrated electronic referral and consultation system that we use to streamline the appropriateness of medical referrals, including those for medical imaging. I'll start off by giving you some background about why we developed eReferral, walk you through the model, share with you some of the measurable impact that eReferral has had on our system, and then describe to you a little bit how we've tailored it to radiology, talk briefly about the facilitators and challenges to implementation and spread, and finish with the policy implications. I wanted to start off by giving you a sense of the delivery system in which eReferral was developed and implemented. So San Francisco General Hospital is a public hospital for San Francisco. It's staffed by UCSF faculty and trainees. Its referral network is a variety of primary care clinics, both within the Department of Public Health and outside. You can see in the middle box that our payer mix is primarily tilted towards the uninsured and the Medi-Cal population, and that we see about 580,000 ambulatory visits. Importantly, the specialists in our system are salaried academic faculty specialists, and everyone in the system has access to the hospital EMR. So unless you get your care at an integrated delivery system like Kaiser or the VA or group health, this slide probably describes your primary care specialty care interaction. So for those systems that have not yet gone to EMR, most referrals are done by paper, telephone, faxes. It's a clerical, not clinical process of the first patient who's referred as the first patient who's scheduled. And in our system, if you wanted to get a patient seen before the next available appointment, you had to page the specialist, plead your case to get them in earlier. Embedded in this are significant inefficiencies. So, for example, referral to the wrong clinic. If you refer someone to endocrine, they may wait for 4 months. When they get in, realize that they actually belong in diabetes clinic. Premature referrals, where the first precious specialty visit is one where the specialist spends their time filling out lab slips rather than having all the diagnostic information available to them. And then inability to discern the referral question in our system. We have many limited English proficient and low literacy patients. And given a paper-based system where the paper may not be there with the patient, sometimes it was impossible to know why the patient was there. And then, as I described before, lack of equitable triage. And in our system, because there's a big supply-demand mismatch in terms of being the only true source of specialty care for all the uninsured, there are long wait times. And back in 2005, when we first started the system, wait times were as long as 11 months for a routine visit in some of our clinics. So, in that system, this was the best case scenario. So this is a case where the patient was referred by their PCP, the fax was received, the machine was not broken, the patient received an appointment, showed up for the appointment, the specialist wrote a note and faxed it back. And when we looked at this, we said, can't we do better than this? And that was the genesis of eReferral. So eReferral is a homegrown, HIPAA-compliant, web-based referral and consultation system. It's very tightly integrated with our EMR. There's a lot of auto-population of data to prevent the need for manual input. But more importantly than the IT interface is the connectivity between the referring provider and a specialty service. So the key thing about eReferral is that when you submit a referral, it goes into an electronic queue where there's a live specialist clinician on the other side, either a physician or an NP, who actually reviews and responds to each referral. So I'll walk you through the system. So as a primary care provider, I submit my referral. Our system actually overnight pulls from our EMR and appends all the relevant diagnostic and laboratory services to that referral. It goes in the queue, the specialist reviews it. If it's appropriate and the referral workup is complete and non-urgent, it's sent to a scheduling queue for the clerks to schedule next available. If it's urgent, it can be overbooked on the spot. However, if the consult question is unclear, if the pre-referral workup is incomplete, or if it's a condition where the primary care provider really could manage it with some guidance from the specialist, it actually doesn't get scheduled. It gets sent back to the primary care provider, and using the system, you can have an iterative discussion with the specialist reviewer until the patient is either scheduled or never scheduled for an appointment, and the clinical issue is resolved. In terms of the impact, I'll walk you through these different categories. The first obvious one is we went from a paper-based system to an electronic one, and we're able to track all our referrals. In the past, we actually had no sense of what the actual volume of referrals were. We knew how many patients were seen in specialty clinic, but we had no sense of the completion rate for referrals. So now we can track all this. We can sort it by referring provider, referring clinic, specialty clinic. This in some ways represents the crux of what eReferral does. So here you have two dashboards, and the reason I show you two is because you can see that there's variation among services. The dark blue line at the bottom represents those visits or those referrals that are overbooked, so the clinical triage. The middle blue bar are referrals that were scheduled routinely. The light blue bar are those who were not initially scheduled, but after some back and forth end up getting scheduled, and the red bar is those that were never scheduled. And by that, we define that as 6 months after the last interaction, there's no appointment in the system. So you can see that this bottom bar, as I had mentioned, is a triage function. The light blue bar represents a savings of at least one visit. So that visit that in the past would have been spent collecting basic data, actionable data, is no longer needed. And the red bar represents kind of a permanent savings of a specialty visit. All these efficiencies and kind of culling out the different types of referrals, virtual co-management in that top red group has led to a significant drop in wait times in most of the clinics that we implemented this in. This is a graph of the wait times of the first 6 medical subspecialty clinics. And we see this similarly in the, actually in radiology. In terms of specialist efficiencies, we did a study where we looked pre and post eReferral, asking the clinicians who were actually seeing the patient in specialty clinic, how difficult was it to discern the consultative question. You can see on the left, in the medical subspecialties, they started off with about 20% of referrals. They couldn't tell what the referral question was. In the surgical clinics, 40%. And in both of those clinics, it dropped to 10%. When I first saw this, I wondered why it wasn't 0%, and it turns out there are a couple of reasons for that. On the one hand, the person who's reviewing the referral and going back and forth, clarifying things with the referring provider is not typically the person who's seeing the patient in clinic. So you have two different opinions at play. The other one, talking to our specialty reviewers, is that sometimes, even after some back and forth with the primary care provider, you can't really elucidate the question. And at that point, a lot of the specialists feel like, you know, this patient and this provider need our assistance. So they go ahead and schedule the patient. This is another really key part about the system, which is this was in the old system, the extent of the communication between the PCPs and the specialists, beside the formal consultative note. And now what you have is the dialogues that used to happen in the doctor's lounge when we were much more co-located. Now the delivery system is much more dispersed and also much more compressed, geographically dispersed, but temporally compressed. There's a lot less room for actually this back and forth between colleagues. And so here you see an example of a patient who was referred for endocrinology, discussion of secondary hypertension. And the great thing is that this is available in real time in the patient's medical record. So if this patient has been being worked up by the primary care provider and virtually co-managed by the specialist, shows up in the ED for hypertensive crisis, this is available to the ED clinicians. And then lastly, we've done some qualitative studies looking at the impact of eReferral on end users. And really, the take-home message is that it improves communication on a number of fronts. Besides the clarity of consultation and ease of ability of asking questions, there's an educational component where the primary care provider's scope of practice is supported. And I'll just share with you that when we first started eReferral, one of our specialty champions was actually appending book chapters to the referrals as an educational component. We then let him know that it was appreciated, but we needed the Cliff Notes version. So let me talk a little bit about radiology. So in the same way as you saw the paper-based referral for a surgical specialty previously, this is our radiology requisition prior to eReferral. And this is what it is after eReferral. So this is for fluoroscopy. You can see that you can pull down the menu to choose your body part. And I have to mention my colleague, Dr. Alex Ribkin, who's in the Department of Radiology here, is the one who developed this interface to provide some decision support to referring providers, because what we rapidly realized is that a lot of primary care providers and even some of the specialists weren't exactly sure when to order what test. And so you can see for each type of study we offer through eReferral, there's a description of the most common indications for that test. You then go on to a larger form that collects a number of pieces of data, including things not in this particular case, but around patient safety, for example, if someone's on metformin and needs contrast. And then in our population in particular, some of the other psychosocial issues. Do you need an interpreter? Are you homeless? Are we going to be able to contact you? So after this is filled out, it goes through the exact same process as all the other eReferrals. So it goes into electronic queue. There's actually a nurse, a radiology NP, Nancy Omahen, who reviews each one of these and actually responds to them. So here are two very specific examples of the kind of clarification and guidance that Nancy gives to referring providers. So in this first example on the left, I'll just read you the history. Persistent complaints of bilateral leg symptoms that are hard to qualify and right upper extremity similar symptoms. Likely related to anxiety but hard to qualify. Patient has developmental delay and symptoms persistent. So you can see here that this is a pretty vague referral. And Nancy asks back, can you give any more specific information as to why you need a brain CT? As it turns out, this patient was primarily anxious, had been pressuring her clinician for a CT scan, ended up being referred to neurology, who concurred that she had no organic cause for her symptoms and really needed enhanced psychiatric care. So this was a case where the CT was actually never performed because of this clarification. This is an example of a 35-year-old woman who had a mass that was initially evaluated by ultrasound, and they referred her for a CT. And in this case, Nancy guided them into choosing an MRI instead. And what I would say here is that what we've tried to do is, instead of falling into the old rubric of you do whatever tests the primary care provider or the specialist or the referring provider orders the first time, and then follow up by saying, well, here are the findings from this, but we would recommend this better study, we just cut to the chase and go directly to the better study. And in this case, avoid the radiation for CT scans. So this is some of the data we have from radiology. In the far left column, you have the actual study type, and you'll see the volume. The three red columns add up to 100%. So you can see that about 2/3 of referrals are scheduled routinely. About 1 in 5 are actually overbooked or scheduled urgently. And then anywhere between 15 and 20% are actually not initially scheduled. Of those, most of them do eventually get scheduled after some back and forth, but anywhere between 2.5% and 6% of the initial referrals are not scheduled. You can see how this compares to our medical and surgical clinics, where there's a far less percentage of referrals that are overbooked and more that are actually never scheduled. We also have looked at modality change. So what is the benefit of having guidance in terms of preventing that initial CT, MRI, or ultrasound and going to the most appropriate study? And looking across the different services, it's about 1% for each of these modalities. And you can see the data here. So not a large number, but still a savings to our system. I just want to talk briefly about one of our newer initiatives around cost and radiation consciousness. So in this context of scrutiny on value in healthcare and reducing unnecessary testing, as well as consciousness around radiation exposure, we decided to leverage our eReferral system and post some of this information on our website at the point of order entry. So you can see here that we have cost information or monetary information and radiation information. In fact, we had extensive discussion and decided that it was hard to actually determine the cost. Charges, as many of you know, are very variable, so we decided to use Medicare reimbursement as our monetary measurement, and then use the standard measurements for radiation exposure. And you can see here that when you go into order, for example, a CT scan, that besides the clinical decision support, there's actually data around the cost and the radiation exposure. We're now doing some focus groups and surveys of end users to see whether they found this information useful, what additional information they might need in order to have it be applicable to clinical practice. So I just wanted to start wrapping up by talking about some of the facilitators for implementing a system like eReferral. One is, there's a typo here, but access to a common EHR was really critical. The other thing is we haven't invested a lot of time in training end users, so we've really relied on an intuitive design. One of the key components is having specialist reviewers who are salaried and used to educating their peers and committed to underserved patients. Ours in particular are very attuned to kind of limited resources and how to make those resources most value added. And then lastly, our system has had a long-standing commitment to primary care and this idea of a patient-centered medical home. And the idea of eReferral is very much to keep things within the patient-centered medical home whenever possible and only refer people out when needed. Not so applicable for diagnostic studies. And then some of the challenges, it's a homegrown system, not a vendor-based system, so it requires some TLC. We do have variability among our specialist reviewers. We try to have one per service. So for example, in radiology, we have one single reviewer for the 3 different services. There is variability among the primary care providers as well, and as we implement a new EHR, there are issues with integration. I wanted to end on some policy implications. There is significant potential for HIT, health information technology, to improve communication and efficiency of primary care specialty care, including that for medical imaging. There is a big role for a system like this in terms of enhancing the patient-centered medical home and putting the primary care provider in a position to have virtual co-management support rather than being a gatekeeper to specialty care. And as accountable care organizations spread, we suspect this model will be adopted widely. This is our eReferral team. Thank you very much.